I'm Pia Francisco Natanuan. I'm an adolescent and young adult medicine specialist. I'm here at Kapilani, also with JABSOM. Today's talk is physician-led is so long. Physician-led comprehensive sexuality education in the schools. I wish to lessons learned from a community-based project. Thank you, Peds Echo, for this invitation. I think I got this invitation like over a year ago. So um, this is still fresh. Disclosure none. I'm hoping that the audience, and I'm grateful that I see familiar and unfamiliar names. We would expand our knowledge on comprehensive sex ed, which we can refer to as CSE. We'll talk about the findings of the Hawaii Community CSE project, and we'll explore opportunities to counsel about CSE topics in our offices. And okay, pretest number one, sex ed in the state of Hawaii or Department of Education is mandated in our classrooms. Is it true or false? I will imagine the Jeopardy song playing, and then I will proceed with number two. The decline in U.S. teen pregnancy rate is due to A, abstinence, B, contraceptive use, C, education, D is B and C, E is A, B, and C. All right. Third question. The origin of sex ed or the Chicago experiment was uh, completed in the year A, 1776, B, 1913, C, 1944, D, 2000, E, 2020. And the last question. The Hawaii mandate for sex ed content is in line with the following medical society statements. Is it A, American Academy of Pediatrics, B, American College of Obstetrics and Gynecologists, C, Center for Disease Control and Prevention, D is A and B, E is all of the above. All right. I believe in easy gratification, so you can get your answers in your brains right away. We'll talk a little bit about sex ed background in the United States. Classroom sex ed is the only resource for puberty, healthy relationships, sexual orientation, and gender identity. And in our state, with sex ed, it's mandated. They put particular emphasis on HIV education. What does sex ed entail? Contraception, condoms, abstinence, healthy relationships, sexual decision making, self discipline, dating, sexual violence prevention. Fantastic, isn't it? I'm very happy that our state does this. However, even with this mandate, the delivery in our schools, we don't know. It's left to our teachers. And when do you give it? There's also no mention of it. You can have it in elementary, you can have it in middle school or high school. And historically, too, sex ed is focused on birth control, condom use, and abstinence. This definitely has caused a decline in teen pregnancy rate in the United States. It's abstinence, contraceptive use, and education. So fantastic again. However, how come the US still has the highest teen pregnancy rate in developed countries? That's like, where is the disconnect? And in the US since 1993, adolescents still make up 50% of STDs. Sex ed has been a hot topic across the United States. The differences in policies leave our children and our teenagers without medically sound sex ed. The contention is always this: who should be giving this talk, and what's there to talk about? The origin of sex ed, and you may find it interesting that I asked the date, the year of when the origin of sex ed had begun, because uh, it was the Chicago experiment of 1913. led by Dr. Ella Flagg Young, and this started actually in 1907. The experiment, quote unquote experiment, didn't come out until 1913. Because what year are we now? 2026. This is like over 100 years old question. And we still cannot figure out how best we could provide education on sexuality when humans are sexual beings. This is, I think, very unfortunate. Um, so Dr. Ella Flagg Young provided scientific evidence-based sexual hygiene education on the following: personal sexual hygiene, problems of sexual instincts, and social facts related to venereal disease, called at that time, now we know STDs. The first formal sexual ed program came out, the Chicago Experiment 1913, and this was highly impacted by stakeholders' values and beliefs. Who are the stakeholders? Policymakers, politicians, the likes. Um, it was always based on the belief of abstinence and safe sex. Again, nothing wrong about it, but excuse me. Uh, who definitely should be the stakeholders is always like the hot question, and nobody would seem to have any kind of like resolution about it. So I guess in my objective for today's talk, I do want to have that empowerment to us as clinicians because we see our patients and their families all the time. So um, with CSE in the United States, the comprehensive sexuality education. This came up actually with the CDC this term. So it encompasses not just sex ed. I have another slide for this, but do know that with AAP, how we should go about sex ed is how it's age appropriate and non-judgmental information on puberty, relationships, and sexual health. What does it mean for us as clinicians? We have to know what we're talking about in terms of anatomy and physiological development, especially when it comes to pubertal sequencing and how our teenagers would be thinking. The psychosocial development in early, middle, late, and young adult thinking, we should be very knowledgeable about this. Um, so, in line with this, AAP put out how CSE should be delivered in terms of um, covering human sexual anatomy, sexual reproduction and orientation, gender identity, abstinence and contraception. We should know the reproductive rights and responsibilities for our children with and without chronic health conditions and disabilities. I've been invited to give talks to patients with disabilities in terms of pubertal and sexual relationships, and I think we there's that knowledge gap too for that set of patients and families. And so I'm pretty sure if you are in primary care that you have encountered these questions from the parents in terms of patients with disabilities and pubertal development. ACOG has the same set of recommendations. We ought to provide medically accurate, evidence-based, and age-appropriate information on reproductive health care, and it should begin in early childhood. It should cover normal reproductive development, birth control, barrier protection, cover forms of discussion of forms of sexual expression and healthy sexual, even non-sexual relationships like with friends and family members. Should cover gender identity, sexual orientation, and questioning, recognizing and preventing sexual violence, and how there is informed consent and good communication and decision-making capabilities, even if they are adolescents, in terms of their sexual relationships and non-sexual relationships. We should address these things in all adolescents with also with physical and cognitive disabilities. CDC has the Healthy Schools Initiative, and comprehensive sex ed is part of it. This is meant for teachers, health educators, and administrators, and this is meant for from K to 12. The idea with the Healthy Schools Initiative is to have the behavior outcomes outlined in a 10-item, I guess this, a 10 item goal outcomes. Recognize developmental changes experienced by the kid, by self or others during childhood and adolescence. Help them establish and maintain healthy relationships and treat all people with dignity and respect, especially with regards to their gender identity and sexual orientation. Consent is always part of the conversation, um, advising them to be abstinent and to how to engage in behaviors that will prevent or reduce STDs, including HIV. Engage in behaviors that prevent or reduce unintended pregnancy and support others in reducing sexual risk behaviors, avoid pressuring others, and using appropriate health services to promote sexual and reproductive health. Thank goodness we don't have to memorize this. Um, this looks like a mouthful and a handful. CDC has this for us. What I'm trying to say is this. Um, Medical and professional societies do want what's best for our children. And they're all in line in terms of how we should deliver now comprehensive sexuality education. Uh, Hang on a second. No, that is not what I wanted. Let me cover that back again. Uh, it's these guys that have a different color. And if you're colorblind, I'm so sorry. I wasn't thinking about that. But sex ed is not just contraception and abstinence. Um, and avoidance of STDs. It's talking about puberty, uh, sexual orientation, gender identity, reproductive rights and responsibilities, talking about healthy relationships with friends and families, talking about good communication and consent. And that we should recognize that we need to talk to our teenagers about this, uh, even with our patients who have chronic medical conditions and cognitive disabilities. And this extends to our school's health promotion. I have no other qualms about how we clinicians can definitely do this in um, every time that we have the opportunity to talk to our patients and the families. You can start as early as prepubertal time. Um, because education extends always to the families so that you can have your patient the care that they need. What we know in the literature is this is only one literature. This is a local study that was done by Dr. Gregerson and company on how we found that clinicians lack the skill to support comprehensive sex ed topics in our offices. And that's a huge, that's a big statement. That could be because we lack the time, not necessarily the skills. But I'm hoping, you would incorporate that skill set because we counsel the kids and the families all the time. What this study did was they went to a public school and taught puberty to fifth graders. And they got the feedback from the students that they learned so much from the presentation and that they had actually more legitimate questions about puberty that we think would be covered in the mandated sex ed classroom talks. Um, so out of this study, they've they had that conclusion, and what they thought what would be good is to have longitudinal sex ed curriculum for the schools, and also maybe having this opportunity for us clinicians to do this if we have the time and the effort and the commitment to do this actually in the community, aside from the clinics. So the skills that were identified kind of like lacking is a big term, kind of like where we need a knowledge gap to be closer is puberty, talking about just the places, the right terms for human sexual anatomy, like actually using the right terms, meaning like we're not giving nicknames to the vagina, the vulva, the penis. It's actually very helpful for the patients and the families. um, Knowing what to expect for the families. Like your adolescent is growing. When they're early adolescent, you're still their best friend. When they're middle, you're not their best friend. They want to go out with their friends and they start dating. Um, Having these expectations so that the families are not hurt and they would know what to expect with their teenagers. Sexual orientation, everyone has one. They're sure they can have a variety right now, and that's very normal. Um, what is more important is that the families are better informed and that the patients are better informed. Reproductive rights and responsibilities. If you don't know much about it, I guess we ought to know that in our state, adolescent privacy laws apply starting at age 14 through 17, which means that you can talk to your adolescent patient at that age without consent from the parent on the following things. Um, uh, STD testing and treatment, um, family planning, which includes prenatal care, termination, and contraception. Number three is substance use. Um, this one has a caveat, no, not an asterisk, meaning like the substance use. But then when they're ready for treatment, then you got to get the parents involved. Gender identity. Everyone goes through this too. Gender exploration is very normal for an adolescent, but also covering healthy relationships and internet safety. We kind of tend to forget about this because I guess, we are all older than our patients and this is growing really fast. I don't think they even call it internet. Whatever devices they have, it's a whole nother world out there. We have to learn to adjust to our questions on making sure that our patients are safe anywhere they're thriving. Okay, I'll take a sip. Hang on. I have had the opportunity, I guess the privilege of having very interested colleagues, and at this time, she was a medical student before the Hawaii Community CSE project came to be. The idea was to reach out to our teenagers, get the CSE topics better discussed in an environment that is not threatening, in an environment that they have the ability to speak freely and ask freely without judgment. And we think this is in the schools. And in line with that the research that I showed beforehand, this was kind of validating in a sense to proceed with this project. So this started during the pandemic, and mostly things were virtual. This started with like interested schools. There were a couple of them. Um, a year later into the project, we decided to do a research out of it, and the school that has permitted us to do so, the topic that they had wanted for us to deliver, the CSE topic of interest to them was sexual orientation and gender identity. Meaning the other schools were interested in other topics, puberty, internet safety, relationships, hygiene, menstrual, etc. So this school who had allowed us to do a research, it's Soji. So um, we had ninth and 10th grade students with the goal of discussing Soji as part of their sexual ed curriculum. We had three classes then, and all these classes, we had their permission and parental permission, and the teacher, their health ed class teacher, was present during these conversations. We had a pre and a post session questionnaire. Um, we were talking about sex assigned at birth and gender identity and the range of gender identities, gender roles and stereotypes and sexual orientations. We had videos followed by group discussion. The pre-presentation questions was about gender because this was the interest they had for us. We had asked those and then asked afterwards those definitions for them, and then we let them write in a question that they would like to have, and then also as a measure of like how good the conversation and the videos were. We asked about pre and post biological sex, gender identity expression, presentation, and orientation. Okay. The platform that we used in this project and that we still do is amaze.org. It's a very helpful platform. This was started by teachers who are experts in doctorate levels for comprehensive sex ed, and they renew this every 6 months to a year. They have annual conferences if you are interested. They also have amazejunior.org. I use the videos a lot with like I'm an auntie too. If my girlfriends ask, okay, how do I go about talking about this? I use these videos. So this was the video presentation that we used for this project. The biological sex, rightfully so, this was the response. There were 44% females and more males for those classes that we gave this to. Um, this is the pre-presentation when they were asked their gender identity and sexual orientation, and how they were expressing themselves and the presentation. And some of them have been, more familiar than others in terms of how they would go about between masculine, androgynous, and feminine. So after the presentation, though, it's been a very, I guess, remarkable in terms of like how over 90% reported learning about people's identities, that it's not just boy and girl. Uh, Three-quarters reported learning more about sexual orientation and gender expression. Um, Less than a quarter had learned something about different body parts and how the expression can be different from body parts. So it's overall a good thing that it's a productive time to do. I mean, to sit down and hear doctors talk about this. The free kind of anonymous replies on did the presentation videos help you learn about it? Yes, now they're fully aware and they have some feedback. Like it's a lot of information, but um, overall too, it's a positive impact to them. Um, so then did the videos help? Yes, it's more confusing, but it's still a good thing to talk about. Did the presentations help? No, not really. I'm still so confused. But from my recent hearing, I believe how people show themselves, female, male, or cis, or all that stuff. So part of like the project too is just to get this kids an avenue to be aware, number one. Number two, so that they can have time allotted for them when they can ask away. And they're not threatened or whatsoever. Um, so this one, did the presentations help? No, people switch their gender once they're born. This presentation did help on other aspects. So, so that project, the research was only for that year, but the research provided us evidence that this is a good project in the sense that we are educating our students, rightfully so. Um, and that there is that benefit of exploring this more in the classrooms. This research was done in a private school, and apparently, because in terms of public schools, you would have, I suppose, um, I guess, more rigid policies in terms of research. Um, I'm saying that because it's kind of like a limitation of the research. However, because of that research and the scientific, the evidence behind it, locally we have had interests in this project. The Dream House Charter School, they had this project for them, and they actually had I guess, a study about it too. I'm just not sure if they're doing this regularly, but they had med students give CSE talks to their students in middle school. Um, I don't think the med students are from JABSOM. I want to say AT Stills, but please don't quote me on that because I don't remember right now. A professor, Dr. Oh, two names. No, Dr. Vyukisa Ulihia, Dr. Adalosa from School of uh, Curriculum and Faculty of Education at the University of Auckland had reached out to me about this project because she is doing this project and they are actually doing it from school entry to their high school. So, um, and as, so I guess that's international. Oh, this one is an international too. I've had also the privilege to being contacted by adolescent colleagues in the Philippines in terms of giving this talk to them on how it's been for comprehensive sex ed talks in the schools. So I think we have, wait, who said this? I think AAP said this. Um, Role of us as clinicians for our giving comprehensive sex ed. We have a duty to create a safe and secure environment for our children who are undergoing puberty and exploring their SOGI and experiencing changes in their relationships. Um, we know that adolescence can be a very challenging time as they face external and internal changes in physiological growth and development. I find it very promising that as medical providers, we can apply what we learn from this conversation. We definitely, if you're not feeling so confident, we definitely seek out ways to gain confidence in exploring CSE topics. You can use platforms like amaze.org. And I'd like you to get to a point where you can counsel on these topics very confidently to your patients and their families. Um, oh, sorry. That's okay. I'll go to the pretest. Oh, we're good on time. I'm sorry. Excuse me. My nose is, excuse me. But before we go to pretest questions, I know Dr. Maxim is manning the chat and whatnot, but thoughts,
A lot of the
questions.
chat is fine. Yeah, no rush.
Oh, okay. Should I proceed with the post test or should we do questions?
Um, it's up to you. We have lots of time actually, so
Mhm.
if folks have questions, feel free to put them in the chat. And maybe we can do the test while you're thinking of your questions and doing your test because everyone kind of does it at different pace. Are you talking about going through it or having Morgan like start the poll?
I didn't even know that there was a poll.
We have a poll, yes.
Yeah, I mean, I think so. I know people like tasks, so maybe we should proceed so they will find out and then
Sure.
they'll find out they have
Okay.
to repeat this talk. I'm kidding. It's probably not like that. Yeah.
All
It's not
right,
a
so let's
competency thing.
take a couple of minutes to do it. And what we usually do is we just tell people like it's anonymous. No one can see what who answered what. So don't worry about having the wrong answer. Um, and then if everybody gets it right, we don't have to review it. But if folks are kind of scattered around different answers, then we usually review it and just make sure everyone's on the same page. So take a couple of minutes for this. And once you finish, feel free to drop questions in the chat too.
I take that back. We got to repeat it if you don't. Oh my goodness, I'm sorry.
Oh, you guys are on it today. It's more than 50% of people have already answered the poll.
This is maybe we need to start doing it mid mid presentation.
Okay, we're up to 3/4. This is a really good number. So maybe I have a timer that I can see it's got about 20 seconds left on it. So why don't we go to 2 minutes and then we can end the poll and review any of the answers that folks had a little confusion on.
I tried to submit my questions and I lost connection before I think it was um accepted.
You mean your
Where
answers
do
on the poll?
Yeah, I completed it, but I tried to hit submit and then I lost connection. So how do I go back in and submit it?
I don't think you can resubmit, actually, but this doesn't get you the credit. You get credit for participating and then for filling out the CME the CME survey that you get later. So this is really just for us. So if you know what your answers were as we go through them, then you can just find out if it was the right answer or not. Is that okay?
Yeah, sure, that's fine.
Okay, great. Thanks. So yeah, I think Looks like we ended the poll, and maybe Dr. Francisco, if you wouldn't mind. Looks like everybody got question one right, but there was a little bit of spread on the other questions. So if you could just review the correct answers for 2, 3, and 4, please.
Yes.
Thank you.
Where is it? Okay. Number one, we all got that right. It's true. It's mandated in our state. Lucky our state does that. Okay. Number two, hang on, I'm sorry. Can I bring this down? Uh, the decline in U.S. teen pregnancy rate was due to abstinence contraceptive use. And these two in my brain, you need education for these two. Yeah. You can't just like, oh yeah, it's magically we abstain from sex and we use contraception. So there's that component of comprehensive sex ed. Um, Sex ed helped with getting teen pregnancy rate down, and that's education. And our teens knew about contraceptive use and abstinence. And if you want more particular studies, the Centelli study, which you can find on the NIH, the Journal of Adolescent Health, they kind of like a newer study, 2016, um, the CDC Teen Pregnancy Hub, and the Guttmacher Institute are resources where you can explore how the U.S. teen pregnancy rate actually went down. Um, oops. Number three, I know it's like, it's not really, it's not really a strong test question because it's like memory recall. 1913, and what I'm trying to say with this is over 100 years old. And I just want you to be cognizant of that. And if you're confused, yes, this is probably kind of validating it's been an old problem. But I think if you would err on the side of like resolution, then we can help our patients. The origin of sex ed is like over 100 years old. You can find this not in the medical literature. History of sex ed brief. If you like to, on your downtime, read about it. Maya's smiling. Do you read this? I bet you do.
Uh,
Dr.
I
Baxter.
have not read this, but I do read a lot of nerdy things, including history on my downtime,
This is
because I'm
how we
just
thrive,
nerdy.
right? Yeah.
Yes.
Okay. And now it's so easy. You just hit AI on your phone and it's like instant gratification. Okay. Number four, the Hawaii mandate for sex ed content is in line with um, AAP, ACOG, CDC. So again, it's very reassuring that in our state, the mandate for sex ed is covered is in line, excuse me, with our medical society health statements, and these are the things that should be on the comprehensive sex ed topics. Um, I just don't want you to forget how we deliver this in the classroom. It varies, and I don't think I mentioned in the slide, parents can opt out. So when your kids are in the public school in Hawaii, you will get if you're a parent, the parents will get a memo to say your kid will get this sex ed talk on this day. If you sign this form, that means we will have your child out. They can opt out. Yeah. Um, okay. I think that was it.
Great.
I will stop. Well, is it okay to stop sharing or should I post? I guess
Oh,
it
no,
depends if
that's
there are
great.
questions.
Um, yeah, I think if there's big question, oh my gosh, I'm somehow pinned. I got really huge. Anyway, if there are questions, feel free to put them in the chat, folks. One thing that maybe would be helpful, I see we have a lot of clinicians on today. Um, for those that are not going into the schools just because of being busy clinicians, do you have any specific tips on how to talk to kids, like phrases that you really like to use, or ways to kind of reduce the anxiety or the like embarrassment factor on the part of the kids, or for that matter, for the
True,
providers?
yeah, yeah.
Because I think, sometimes kids are like, oh my God, I'm supposed to talk to a grown-up about this stuff.
Yeah, no,
So have you
I
got
do.
any
I have
like
like kind of
favorite
like
phrases?
I do, and maybe it's kind of like an advantage or not, because I have my own children, and I just pick up from them too. But if you don't have your own kind of set of source of lingo, that's okay too. My approach is, well, not before I say the approach, my go-to first is normalizing with the parents in front of the child how we should say with a straight face, penis, vagina, vulva. Because it's really confusing to our children if you have nicknames for those. And because, I'm in adolescent medicine, I've had the worst ones, meaning I've had kids who were taken advantage because of nicknames. Say the vagina or the vulva is called a nickname like a cookie, and uncle will always ask for the cookie or something like that. Oh, it's just so confusing to kids. When I give the talk to the elementary schools, the teachers appreciate it highly when that's the first thing I say to the kids. Like, don't call it morning wood or whatnot, and then you start giggling. No, that's not right. The penis, vagina, all the reproductive parts are like any other part of our body that we uh, we we ought to say with respect. If we have eyes, we refer to our eyes. Um, and I think it's very helpful for the families and the patients to start with that. As far as like, tricks, I guess the lingo, I let the patients know, hey, these things are very weird to be talking about, especially to a stranger like me. And I would hope that you would have, that's why I would hope you would have this conversation um, with your parents. It's not going to be like cool, it would be cringe, but it's okay. At the end of the day, I would rather you trust the adults in your life when you talk about these things, um, than internet searching it. Because if you do that, number one, if you do it in the school, you'll get in trouble with the school. They will get in trouble, yeah. If you like search whatever on like penis or whatnot, they'll get in trouble with the school. Number two, if you do that somewhere else on your phone or whatnot, you'll get in websites that are just wrong. Lo and behold, those would probably be porn site. By the way, our male adolescents, their first taste of reproductive sex ed is the porn site, which is really wrong. Uh, and people think, usually most of society would think that that's okay. They're going to puberty. It's not. It's just heartbreaking if we think that way. So, and I can talk and talk and talk, but like there's nothing farther from the truth. And how you deliver it, yes, it's key. I'd approach it always with the family um, and the patient. Yes, thank you, Dr. Natarajan.
Yeah, that's a nice way to phrase it too. Like these are science words.
I'm gonna read this question. I don't know if this has been addressed. Does the child have the option to consent to when and on which topics? The children cannot consent on their own because they're children. Uh, if you mean the parents can, yes.
But it would be hard to find a child that was like, yes, I really want to go to the sex ed class. I'm not going to be embarrassed at all. So I think if you gave children an opt out, then you would never get anywhere.
Correct.
Other questions or comments, folks?
Yes,
Okay.
I agree. Um, I don't know how to say your name, Dr. Kadlachek. That was an attempt.
It's a good attempt.
Okay. Okay, well, yeah, thank you for the conversation, everybody. I think, yeah, that the issue of trying to normalize it and making everybody feel comfortable that this is an appropriate topic of conversation and what are safe environments to have these conversations in, and making sure that we are one of those safe environments, but that it isn't all falling to us. Those are all really, really important things that obviously you've done a lot to advance, Dr. Francisco, over the last many years. So
Thank you.
um,
I want to give a shout out. Am I allowed?
please.
I am very thankful for everyone who's on the list, and I guess I know most of you by name. Um, I want to give a shout out, and they're probably going to hate me for doing this, but I see our strong nursing leadership from our facilities and the judiciary. So thank you. You know who you are. I didn't out you completely, but thank you for being here. I can't believe you're here, but I'll see you at work tomorrow.
All right. Well, if there are no more questions, then I'll say thank you so much to Dr. Francisco for a great talk as always. And I know that we all learned a lot from you, as we always do. And everybody else, we will see you in a couple weeks. Looking forward to next time, and enjoy your afternoon.
Thank
Thank
you.
you. Bye.